Hello, everybody. Thanks for clicking on the video. In the previous video, I went through a day in the life. I went through like the typical workflow for a CDI, for a CDI nurse. But today, I'm going to take you through an actual CDI case. But before we get into the CDI case, I'm going to talk about or go more into detail about the skills that are required for a CDI nurse. So sit back and enjoy the show. Here we go. So the purpose and function of CDI, number one, your number one job is to clarify ambiguous clinical documentation. So anything that is unclear or anything that is conflicting, it is your role as a CDI to get it clarified before the patient is discharged. Your next purpose and function is to establish a working DRG. And I'm going to go more into detail about what a DRG is further on in the presentation, but basically DRG stands for Diagnosis Related Group, and what it is how diseases and conditions that people have in an inpatient setting are grouped for payment. And it is your job as a CDI to establish what they call a working DRG. And a working DRG can change based on how the patient's condition, either how they present versus how it deteriorates, or any number of things can happen that can affect the DRG. But it's your job to assign the DRG. And the DRG is um, basically determined by the admission diagnosis, which is an ICD-10-CM code, and any inpatient procedures that they may have while they're in the hospital for that episode of care. And any procedure codes inpatient are coded by ICD-10 PCS. So it is a combination of those two code sets that you can produce a DRG. Now, you will always have an ICD-10-CM code, but you will not necessarily always have a procedure code because not all inpatient stays require a medical or surgical procedure. Then the next purpose and function is the liaison between clinical and coding. So once you finish with your case and the patient is discharged, that entire case goes to coding, and a medical coder will code the case, and that will generate the final bill that will be submitted to an insurance payer for payment. Now, if there is any kind of discrepancy, if the coder doesn't agree with what you've coded, or you may have overlooked something and a coder reaches out and says, well, I think we need to get this clarified, then that is where your role comes in, because we are the liaison between the coding department and the providers. So if another query needs to be sent, then the CDI nurse will write the query and will send it to the provider. Then based on a response, the coding may or may not be updated, which would require another bill to be submitted, but coding handles that. Then lastly, your purpose and function is to validate reimbursement. Now, a lot of people think that it is CDI's job to increase optimize reimbursement. It is your job to validate. So whatever the medical record substantiates, that is what you are required to make sure it's clinically supported. So if you have a diagnosis, then did the diagnosis meet the criteria for it to be coded? And that includes clinical validation. So was there treatment? There's a whole number of things that go into clinical validation, but it is your job to validate the reimbursement. So that's you want to make sure. So if you have a claim or a case that only has one MCC and the DRG is affected by an MCC, you want to make sure that that MCC is fully supported. So when it's submitted to the payer cannot say, oh, well, this did not meet criteria, and we're going to reduce the DRG and reduce payment. So now we're going to talk about the required skills for an inpatient CDI. Now, I'm going to say something that is extremely controversial in CDI. I personally believe that especially nowadays. Now, I don't know how it was prior to me getting into CDI, prior to, the early 2020s. But it is imperative now that a nurse knows medical coding, because the sweet spot for CDI, in my opinion, is to have a clinical background, to have clinical knowledge, and to also have medical coding knowledge. That is the sweet spot. Now, there will be people out here who will debate me that, oh, well, a nurse doesn't have to know doesn't have to know medical coding in order to do CDI. That used to be the case, but I don't think it's any longer the case. And I know for me, when I was doing inpatient CDI, my medical coding knowledge and my clinical knowledge is what made me do as well as I did. I mean, it really, really, I could not have imagined the learning curve that someone would have to go through if they did not have a medical coding knowledge, a medical coding background. Because how can you assign an appropriate working DRG if you don't even know how to code, if you don't even know the coding guidelines? Because there are some conditions that what someone is admitted for cannot be the principal diagnosis. So, but you would only know that if you know coding. So I'm going to say that you need medical coding knowledge, you need a clinical knowledge, which comes from a clinical background, which all nurses have. And lastly, you have to know compliant querying. And when we talk about querying, the number one, the most important um, word in that phrase is compliant, because queries are legal documents and they have to be written a certain way. They have to have certain things included in it, such as uh, clinical indicators. You have to give, when you are asking for clarification and presenting options to the provider, the options have to be clinically sound, and you can only ask for something that is clinically relevant. You cannot pull a rabbit out of your hat and ask for something that is not there, where there are no clinical indicators to support a diagnosis for that particular thing. Now we're going to go a little bit more into detail about DRGs, because DRGs are part of they're the backbone of the inpatient prospective payment system. So the inpatient prospective payment system is how inpatient stays are paid by Medicare and commercial payers. Then conversely, there's an outpatient prospective payment system that governs how outpatient and professional fees for providers are um, billed and paid. So in the inpatient prospective payment system, we have two types of DRGs. We have an MS-DRG, which is medical severity DRG, and we have an APR-DRG, which is all patient refined DRG. So starting with MS-DRG, those are for people over 65 and disabled. And MS-DRGs are managed by CMS because they are typically Medicare patients. And MS-DRGs, the MS-DRG weight is affected by CCs and MCCs. And when we have APR-DRGs, they are for commercial payers or anyone that's pretty much non-Medicare, and they are determined by SOI, which is severity of illness, and ROM, which is risk of mortality. Now, I'm going to go a little bit more into detail into both of these, but the DRG weight for APR DRGs are determined by the severity of illness. And this is in the last bullet, it says affected by SOI. So that will determine the DRG weight for that DRG. So with the medical severity DRG hierarchy, at the base, we have no CC or MCC. And CC stands for complication or comorbidity, and MCC is major complication or comorbidity. So what a complication or comorbidity is any secondary diagnoses that the person has at the time that they're admitted that can affect or they could develop it afterwards depending on what happens, but it is a secondary diagnosis that can affect the DRG. Now, I don't want to get too far into detail, but there are some DRGs that are standalone. So, which it means that there's nothing like a CC or an MCC1 affected at all. And then there are some that are affected by CCs and MCCs. So when it comes to the MS-DRG weight, the highest weight is an MCC. Is a DRG with an MCC, then the second highest weight is a DRG with a CC. Then the lowest weight is a DRG with no CC or MCC. Now going back to APR-DRGs. So we have SOI and ROM. Once again, SOI is severity of illness, and ROM is risk of mortality. Now, both of these scores are weighted on a scale of 1 to 4. So each one will have a number assigned 1 to 4 based off of the diagnosis and the secondary diagnoses that the person has while they're admitted. And 1 is minor, 2 is moderate, 3 is major, and 4 is extreme. And once again, the weight, the DRG weight for APR-DRGs is determined by the severity of illness. Now we're going to run through a quick inpatient case study. So in the case study, we have a 67-year-old female presented to the ED emergency department with nausea and vomiting times 2 days, fever, and a cough for 1 day. Past medical history is dysphagia secondary to CVA or stroke several years ago. Chest x-ray showed bilateral lower lobe infiltrates, and patient was admitted with diagnosis of pneumonia, treated with IV cefepime for 4 days, and was discharged on oral antibiotics. So that's pretty much our case study. So what you have to do as the CDI is you have to establish a working DRG, and you have to make sure that that DRG is validated, and you have to make sure that there's no there's nothing left on the table. So if there is clarification, then you would need to send a query based on what you see in the clinical documentation. So in this scenario, I can tell you that there is a query opportunity, and we're going to delve a little deeper into it. So first, we're going to look at the validation criteria for pneumonia. So for pneumonia, you need a diagnosis, which we have because the patient was diagnosed with pneumonia. We have signs and symptoms. The person had a cough and they had a fever and nausea and vomiting. They also had imaging of proof of pneumonia. They had chest x-ray with bilateral infiltrates, and we had treatment. They were treated with IV cefepime, and they were discharged on oral antibiotics. So now we're going to look at the criteria, the validation criteria for aspiration pneumonia. So aspiration pneumonia, we have all of the criteria that is for pneumonia, but we have one extra one, which is contributing factor or factors and or underlying condition or conditions. So this patient did have an underlying condition because they had dysphagia secondary to a stroke several years ago. So that could be a contributing factor, and it could be that would be a clinical indicator for potential aspiration pneumonia. Plus, they also had nausea and vomiting for 2 days prior to admission. So when we get to our query opportunity, the query opportunity is we need specificity of the type of pneumonia. So when we look at the clinical indicators, we have nausea and vomiting times 2 days. We have dysphagia secondary to a stroke. We have bilateral lower lobe infiltrates, and we also had treatment with IV cefepime. So we would type this up and send to the hospitalist or to the attending physician, because in an inpatient setting, the attending physician, or they call them now hospitalists, they pretty much run the show, and they're in charge of that person's case. So when we get to the options, we have an option of aspiration pneumonia. we have pneumonia unspecified, and we have other, please specify. So to make a query compliant, we can only suggest conditions that are clinically supported. So based on how the person presented with their signs and symptoms and treatment, we can see if the person has aspiration pneumonia, or if the provider feels as though it's just regular pneumonia. And also in a query, you always have to leave a space for other, because the provider may not agree with what you have suggested. They may say, well, it's neither one, it's whatever, and they have that space in other to document what they feel the query or the type of pneumonia would be. So now we're going to get into the results based off of, we're going to have a query response that was pneumonia, then we're going to have a query response that was aspiration pneumonia, and we'll see how that plays out with the DRG. And for this case, we're going to do MS-DRG. So we see, so this is a solventum, or formerly known as 3M encoder, which you pretty much use almost all the time in inpatient. I've never worked anywhere where they didn't have solventum as an encoder, or 3M. So as we see, we have pneumonia as a principal diagnosis. And we see that at the very top, we see that we have a DRG, and we have a DRG weight. So, and we have, if we look at under Medicare DRG and MDC information, which is the green bar right under ICD-10-CM summary under message and edits, it says simple pneumonia and pleurisy without CC/MCC. So this means that this person had no secondary conditions that during this admission that would affect the DRG, and that DRG is 195. And we see that we have a dollar amount under total, so we're going to keep that in mind. We're going to get to that in another slide. Now we're going to look at the DRG if the query came back that it was aspiration pneumonia. So if we look at aspiration pneumonia as the primary or as the principal diagnosis, we see that we have a DRG of 179. Looking again under Medicare DRG and MDC information. So we have respiratory infection and inflammations without CC or MCC. So we see we have a DRG of 179. We have a different weight, and we have a different total, or a dollar amount. Now that dollar amount is not etched in stone, because there are many more factors that go into a final payment for an institution, because there's a formula that the DRG weight gets factored into, that they have to go through. It's based on geography. There are a few other things that go into it, but this is just like maybe a ballpark figure, or just to give you an idea of what the final reimbursement would be for this particular DRG. So we see with the principal diagnosis of pneumonia unspecified, which is J18.9, we have a DRG of 195. We have a DRG weight of 0.6285, and we have a reimbursement of $3,273.64. If we look at the principal diagnosis of aspiration pneumonia, which is J69.0, we have a DRG of 179. We have a DRG weight of 0.755, and we have a reimbursement of $3,872.78. So by sending a query, and if the provider says that this person did have aspiration pneumonia, which they did meet clinical criteria for aspiration pneumonia, you have increased the reimbursement for this hospital by $599.14. And this is just because that dollar amount, the $599, is because it's a CC, it's without a CC or MCC. So if there were an MCC or an MCC on this case, that financial impact would have been more. So this is why CDI is so important to a hospital, just to help them clarify documentation and to make sure that all of the work that the providers are doing is reflected in the coding and in the final billing. And with that, that concludes my demonstration. And as you can see, I have at the bottom of the screen, at the bottom of the thank you, is my email address. And if you want to learn more about how to become a CDI nurse, I also have my website. You can visit me at www.thecodingnurse.com. And I thank you for watching the presentation. Hope you got something from it. Thanks. Talk to you later.